Woohoo! Morning, everyone. Hey, Matt, how are you?
Good morning. How are you doing?
Good. Very excited for our presentation since I missed yours months ago when you gave it to the physician group.
Yeah.
Good morning, everyone. We'll just give everybody a few minutes to log in and then we'll get started by 9:05. So we have an awesome presentation today just talking about the role of buprenorphine. And then we have a case presentation, which is a pretty good one. It's for a pregnant female with chronic pain, mental health, and we should be able to learn a lot from that.
Miss Bloomberg, do you think I would be able to be made the host so that I can share my screen?
Yeah. Let's see how good mine.
I can do it. Hold on.
Okay, thank you.
Actually, like I haven't had enough coffee this morning for technical. I'm just kidding.
You should have full power now.
Okay, awesome. Thank you.
You should be in like 2 minutes. Do you want to do general housekeeping and then we can get started?
Sure. Should I go ahead and get started?
We'll do like 1 more minute just since we had a little technical issues, and then we can, in lieu of the time, we get started. I think we can get started if you want to start with the housekeeping and whatnot.
Yeah, of course. So good morning, everyone. My name is Anushka, and I currently serve as one of the UAB ambassadors, and I'll be helping to moderate this event. Let's see. So we'll go ahead and go through some of the housekeeping rules. So just to keep cameras on throughout the session, position the webcam effectively, as well as muting the microphone whenever you're not speaking. And then also remaining and respecting private health information by excluding names, employers, birth dates, or other common identifiers. And then also wanted to keep going that these are the accreditation statement and the EOE statement from the UAB accreditation office. And then there aren't going to be any disclosures for this echo. And this does count as CME credit. So just to record some attendance, here's the QR code. And then I can also pull up the link if that's easier. So let me just put the link in the chat and then I will.
Perfect. Thank you so much. So I'm very excited to have our own PharmD with us today, Matthew. I realize I've never actually said your last name or referred to, so I might be butchering this, but we have Matthew Hermenau maybe, who earned his doctorate of pharmacy at the University of Rhode Island in 2018. And then he went on to complete his PG1 at Providence, Rhode Island, VA Medical Center, and a PGY2 in pain management and palliative care at the University of Florida Health in Jacksonville, Florida. He is a nationally board certified health and wellness coach. He's a personal trainer and works as our inpatient pain stewardship clinical pharmacist at Jackson Memorial Hospital in Miami, Florida. His areas of interest lie in acute and chronic pain and preventative medicine through lifestyle optimization. And I just feel so fortunate to have Matt part of our team. He really has been integral with helping us transition patients to Suboxone. And I think his extracurricular activities with health and wellness, et cetera, has really allowed us to take a more holistic approach when managing our patients and suggesting different labs and identifying different things that can be contributing to pain beyond the sickle cell. So I'm extremely excited to have him here today and just teach us a little bit on the role of buprenorphine. So with that, I will hand it off to you. And Matt, you should be able to share your screen.
All right. Thank you, Maya. It says host disabled participant screen sharing.
Ashley, do you mind giving him the host ability as well for Anushka?
I believe it should work now, hopefully.
Yeah, now it's working. Thank you.
Mhm.
All right. Okay, so is this viewable? Can everyone see the slides? Okay. So thank you for that introduction. So today we're going to be talking about the role of buprenorphine in chronic pain due to sickle cell disease. And initially I gave this talk on solely Suboxone and kind of how to do a microinduction with Suboxone for someone that was on methadone previously and high dose opioids. But today's talk is not only going to incorporate that, it's going to incorporate kind of all the different uses of buprenorphine, even the FDA approved indications for pain too. So trying to get the broad spectrum here. I don't have any conflicts of interest, and the views I'm expressing don't necessarily represent my employer, Jackson Health System. We're going to be talking about some off-label uses of buprenorphine. So buprenorphine with naloxone, the sublingual tablets or films are off-label use for chronic pain as their primary uses for opioid use disorder. So today we're going to be exploring the increasing rates of chronic pain with sickle cell due to the increasing life expectancy and talking about the pharmacokinetics and pharmacodynamics of buprenorphine. We're going to review some of the different formulations of buprenorphine for chronic pain, as well as the off-label uses, as I just mentioned. And then we're going to lastly look at some of the most up-to-date literature for using buprenorphine in chronic pain due to sickle cell. So what is the landscape right now, or the chronic pain forecast for sickle cell disease? And this is an interesting statistic that I'm seeing more of, where chronic pain is more prevalent, and 55% of patients are experiencing pain more than 50% of the day. And then you have 29% of patients experience pain more than at least 95% of the day. So when we look at the historical timeline, even from just 2008 to present day, we've seen a pretty significant increase in the lifespan for someone with sickle cell disease. And now we even have like curative treatments coming out, which is amazing. And I think more and more we're seeing that the lifespan is being prolonged with patients that have sickle cell. So naturally, you may develop some of these more prolonged chronic pain episodes with avascular necrosis of the joints. Maybe you get a hip replacement or a shoulder replacement, and you're still going to have chronic pain. It's not like it's going to go away completely. So I suspect that as we're kind of having more life prolonging therapies come out, which is amazing, the life expectancy will increase, will further increase for sickle cell, and you might see more patients that have chronic pain. And if you look at the 1990s, the median age at death for patients, male or female, was much lower than what it is today. So it's definitely making strides, and it's important just to bring this up, though. So let's go into the PK and PD about buprenorphine. So buprenorphine's mechanism is a high affinity partial agonist at the mu-opioid receptor. And it's also got this alternative mechanism as a full agonist at the ORL1, or opioid receptor, opioid-like receptor 1 receptor. It's also a weak kappa antagonist, so they theoretically believe this might be helping with depression because it actually has some effects on that. But the biggest thing is that it has a significantly higher potency or affinity for the mu-opioid receptor as compared to morphine. actually 10 to 100 times more potent. So when we're looking at buprenorphine, though, the reason why it's so unique is that just because it's a partial agonist doesn't mean that it has like a partial analgesic effect. So it actually has a ceiling effect for respiratory depression, where on the next slide we'll talk about that more. But as you further increase the doses, you don't see the kind of increase in respiratory depression through beta arrest and recruitment like you would with morphine or Dilaudid or fentanyl. It also has a reduced amount of allergic reactions, constipation, nausea, vomiting, and hypogonadism. So some of the more common adverse reactions with main full agonists. So its half-life is very long. It's about 24 to 42 hours. For a pain medication, it's quite a long time. It's could basically be looked at as a long-acting opioid if you want to break it down to its nuts and bolts. Its duration for analgesia is 6 to 8 hours, which again is relatively long for that of a longer acting agent compared to like your more shorter acting agents that maybe 4 to 6 hours, like morphine, Dilaudid, fentanyl even shorter. And like I mentioned, at therapeutic doses, the risk of respiratory depression appears to be lower than that of some mu receptor agonists, the full agents, the full agonists. And this is through less beta arrestin and recruitment. But at the same point in time, when you add on benzodiazepines, anticonvulsant agents like gabapentinoids, or other Z drugs like zolpidem, Lunesta, it can kind of lower the ceiling effect, making it similar to a full agonist, and you still can't have an overdose with it. Alcohol as well is like something really important to counsel on with any opioid, to just be very cautious of like consuming them both at the same time. So the regulations for buprenorphine have changed over the years. It's a C3 drug, so Schedule 3, but there's no more restrictions with the data or DATA waiver for Suboxone or Subutex. So you don't need to do all this additional training and like have it sign up with the SAMHSA to prescribe it off-label for pain or addiction even. And its half-life, as I mentioned, it's pretty long half-life, so 37 hours. The adverse effects are, as I mentioned, it's pretty similar, but you have a reduction in side effects compared to that of a full agonist. Peripheral edema is a new one. I actually went to a conference recently and someone asked about that. I've never had a patient experience peripheral edema with buprenorphine, but it's a listed side effect to be aware of. And then dose adjustments. So this is a great area that you can definitely be aware of if they have hepatic impairment. So moderate to severe hepatic impairment, you really want to be cautious about even starting buprenorphine because it's really heavily metabolized by CYP3A4. So if you do start it, just start at like a much lower dose, at least 50% reduction when you're starting. There are no renal impairment adjustments with it. So even if someone has AKI or if they're on dialysis, you can still give them this medication. So what are the different formulations of buprenorphine for chronic pain? There are Butrans patch, Belbuca, which is a buccal film you can put on the side of the cheek, and those are both FDA approved for pain. And then there's plain buprenorphine sublingual tablet, which is Subutex, or the combination buprenorphine naloxone tablet or film, which is Suboxone as a brand name. And those are off-label use for chronic pain. So let's talk about Butrans. Butrans is a great agent for someone who's pretty naive to opioids, and there are multiple doses that it can be started and trialed with. So usually patients will start off with a 5 microgram per hour dose. That's like kind of the introductory dose that you can start someone with. It's a transdermal patch that has a very long duration of action. So it's supposed to be for 7 days. Sometimes it may last up to 5 days for some patients who've been on it a very long period of time, but generally speaking, it's a patch put on every 7 days. And steady state is achieved within 3 days. So how would you go about dosing Butrans? As I mentioned, it's a great option for someone who's opioid naive, and you kind of don't want to start them on a full agonist agent, and maybe want to try something that's more like benign, that's not going to oversedate them. So if you have a patient that's opioid naive, or if they're using under 30 oral morphine equivalents per day, you really want to make sure you're trialing non-opioids and adjuvants first. So like alternative agents like NSAIDs, Tylenol, gabapentinoids as appropriate, SNRIs if it's appropriate too. And then those patients would qualify for a dose that's 5 micrograms per hour. And then if you have someone who's not opioid naive, but they're still using a pretty low amount of opioids, so 30 to 80 oral morphine equivalents per day, it's actually kind of interesting the way you go about starting it. So The recommendations from the manufacturer are to taper the current around-the-clock opioid for up to 7 days to try to get to underneath 30 morphine milliequivalents per day before initiating therapy. If you're not there, it's okay. It's not doesn't have to be perfect, but they just kind of recommend that to start for an easier transition. And then you'd initiate a dose that's 10 micrograms per hour for the patch, and it's again a weekly patch that's put on. You can increase this dose in those kind of increments of 5, 7.5, or 10 microgram usually every 72 hours at a minimum amount. So you want to, if you were to start this for someone, you want to definitely, we put the patch on them, they try it for a week. Usually they'll do it for like 2 weeks and we'll have the patient come back. And after they get stabilized, it's usually like monthly visits and they're pretty controlled. The biggest thing with Butrans, if you're not opioid naive and you've been using more than 80 milligrams of morphine per day, it's probably not going to provide adequate analgesia. So this is again, an agent that's for lower doses of opioids that patients are taking, and it's an option for them. Administration of it, just apply it to a hairless or nearly hairless site. The deltoid or outer arm, the chest, scapula, and then like the ribs can be areas where you can apply it to. And you don't want to cut the patch. So it's just like fentanyl patch. You're not supposed to cut it. What if the patch falls off during the 7 days? You just put a new patch on at a different skin site. And you can't apply 2 patches at once. That is something that some providers will have to do sometimes, but the max FDA approved dose is 20 micrograms total. So let's talk about Belbuca now. So Belbuca is the buccal absorption. So you put it on the side of your cheek. And it's a different way of delivering buprenorphine that has a higher bioavailability. It's about roughly 50%. Comparatively to like Suboxone or Subutex, they have about a 30% bioavailability. The dosing is totally different for these two drugs though, but in terms of bioavailability, it's higher for Belbuca. Its duration is very long, so half has a duration of 12 hours, so usually it'll be dosed twice a day, almost like a long-acting opioid, and it has a longer elimination half-life too. So the dosing for Belbuca is, in a way, somewhat similar to Butrans. You have different like tiers of like what dose you would start someone on based on how much milligrams of morphine they're using prior to starting Belbuca. So if they are using under 30 milligrams of morphine per day, again, they recommend tapering the dose of whatever opioid they were using previously, a short acting, to be under or around that amount for an easier transition. And at that point in time, you could start, you want to determine the appropriate analgesic dose by considering the previous full opioid agonist MME per day before the taper. So sorry, a lot of words there, but essentially before you do a taper, understand what they were using beforehand. And once you achieve the taper to around 30 milligrams of morphine per day, then you would use their previous amount to dose Belbuca. So if someone's on, say, 75 milligrams of morphine per day, you're going to try and taper the dose to around 30 milligrams of morphine per day prior to starting Belbuca. And then once you start Belbuca, like 12 hours after stopping the full agonist, you would start 150 micrograms because it falls within that bucket of 30 to 89 milligrams of morphine per day. And titrations are at most every 4 days. This is a faster titration than that of Butrans because it's something that's dosed twice a day, and the Butrans is once weekly. So with Belbuca, I tell people that it's going to take some time to achieve a optimal pain, like pain tolerance or analgesic effect. So usually with Butrans too, but they studied this with Belbuca where it took about 24 days in the study to get to a dose that was helping the patients the most with their pain. And it's important to counsel the patients that it's actually okay to use a PRN opioid during the tapering or induction of buprenorphine because it's such a low dose of buprenorphine in micrograms that's not going to precipitate withdrawal if they're trying a PRN full agonist agent in addition to it. It has greater potency than the Butrans patch, so its doses go up to 900 micrograms potentially, and the Butrans patch was like up to 20 micrograms per hour in a 24-hour period, but had a lower bioavailability. So the biggest thing that I can tell you in the randomized trial with Belbuca is that 84% of the patients at the end of the trial were using a dose between 450 micrograms per day to 900 micrograms per day. So usually our patients' range of what pain control through dosing is around this kind of tier. But everybody's different and they may not require that specific dose, but just to give you an idea. So now let's talk about Suboxone or Subutex. So this is really different than the prior two agents I just mentioned that were used and FDA approved for pain. This is off-label dosing for pain, and its dosing is in milligrams. So that's the biggest thing I want to stress, that it's dosed in milligrams. Butrans and Belbuca is dosed in micrograms. So this is a much more potent version of buprenorphine versus Butrans and Belbuca for maybe someone who's opioid naive or on lower doses of opioids. The Suboxone or Subutex can be considered for someone that's on much higher doses of opioids, and the rationale for like trying to start it is that it has alternative binding effects with ORL1 and a lower risk of respiratory depression versus that of a full agonist. So the patients might feel clearer or more mentally like focused when they're not on like the full agonist agent and they start Suboxone or Subutex. So generally, it's a 4-to-1 ratio of buprenorphine to naloxone, and the dosing is listed there. For Suboxone, for buprenorphine generic or Subutex, it's just in a 2 and 8 milligram tablet of buprenorphine. The naloxone component is only there for abuse deterrence if someone were to actually inject it. This is, again, when it was first used for opioid use disorder, this was a worry for patients. And I've never had a patient actually with opioid use disorder tell me they've injected Suboxone, but if it's taken sublingually, the naloxone component is supposed to be destroyed in the gut and have really bad bioavailability, so it will not affect anything if they're taking it as directed under the tongue. Its bioavailability is about 30%, and the duration there, it's a little typo, I apologize for that, should be 8 to 24 hours, and its elimination half-life is very long, it's 38 hours. So what would be the ideal candidates for Suboxone or Subutex? I think the biggest one is that they're dissatisfied with their full agonist opioid, and they're using more than 90 oral morphine equivalents per day. So usually I'll talk to patients, I'll be like, are you having like a lack of pain response to like the full agonist agent you're taking? Are you maybe having poor functionality? So do you find that you're fogged out all day and you can't do the daily activities, or you want to like a lot of patients have kids and they want to like work, like have a job and go to school. So are you not able to do those kind of like daily activities of daily living, or IADLs even, definitely, where the meds are getting in the way of that? Do you have a history of obstructive sleep apnea, BMI greater than 30, or you prescribed a concomitant benzodiazepine? And the reason why here buprenorphine may be an option is that, again, it has a lower risk of respiratory depression with less beta-arrestin recruitment versus that of a full agonist. Are you prescribed a short-acting opioid at baseline and no long-acting agents, i.e. methadone? And this is something that we've definitely like pursued with our own patients, where patients on methadone, it's very challenging to transition them to buprenorphine. It's not impossible. You just have to definitely counsel the person on how they may experience withdrawal off methadone for several months, even if depending on how long they've been on it for pain. So if they're only on a short-acting agent, that usually will wash out of their system pretty fast because it has a much like shorter half-life. And then lastly, are they having frequent hospital admissions or ED visits due to uncontrolled pain? And obviously you want to optimize their therapies for sickle cell disease before we just give them pain medications. But this is something that I always consider when talking with patients. So what's the evidence really for Suboxone or Subutex in sickle cell disease? And this is a study that came out pretty recently, this past year, by Dr. Cantor at the University of Alabama and others. It was a real-world implementation of the David Carroll buprenorphine protocol for pain management in sickle cell, and it was a retrospective chart review at UAB. So generally speaking, they did a 6-month pre and post-induction study period where there were about 30 patients, and the mean age was 30 years old, and 81% of them had sickle cell, like hemoglobin SS. They excluded 10 patients after the trial had finished due to 5 of them receiving transformative therapy. 4 of them actually discontinued buprenorphine due to the lack of benefit from it, and 1 patient had sickle cell trait. 50% were receiving hydroxyurea or crizanlizumab, and 28% received chronic red blood cell transfusion. And the patients during this trial, their acute pain management usually included IV or IM buprenorphine at their hospital. They also tried to pursue IV Tylenol, ketorolac if it was applicable, hydration, and then they switched over to full agonist opioids if their pain was truly not relieved with buprenorphine agents. So if you look at the pre-induction OMEs, they were on about 118 milligrams morphine per day. So it's right around where we were talking about, greater than 90 per day. Their buprenorphine dosage just when they started the induction phase, so they stopped their full agonist the night before and started the full agonist the day of, that first day, average dose was 10 milligrams of buprenorphine on average. And then they looked at the pre and post amounts of acute care visits, so ED visits, hospitalizations, infusions, and just general acute care visits. And then they looked at non-acute care visits, so more so the outpatient follow-up, psychology, hematology visits. It's more of the outpatient, almost like primary care follow-ups with them. And then they looked at the post-induction phase, so 6 months after. And they found that the dosing had to be increased slightly to about 13 milligrams, but they saw a really great trend in the reduction in the amount of acute care visits. And they found that there was an increase in non-acute care visits alternatively, which was ultimately it's sparing for the hospital because you're not utilizing the resources, but they were all statistically significant as well. So this is a really interesting trial that came out where I think if you employ a lot of social support for patients too and really bolster the outpatient efforts, you can see a lot of good effects from buprenorphine. So how would you start it and what dose would you do? There's 3 different ways. The traditional way is to wait for observable withdrawal symptoms. It can really be unpleasant for patients though if they're withdrawing off of their full agonist opioid, and we don't really do this as often. The 2 different ways that usually you'll see nowadays is microdosing or the stop and start method. So microdosing just means that you're slowly up titrating buprenorphine while continuing the full agonist agent that they're on. And usually this is more beneficial because there's less of a potential for withdrawal, and it's usually better if they're on a short-acting and a long-acting agent at the same time. If you want to do the stop-start method, you basically just stop the full agonist and start buprenorphine at the next dosing interval, so 8 to 12 hours afterwards. It can be very simple and straightforward, and it's more easily pursued if you're only on a short-acting opioid. So here's an example of both of them. On the left is the microdosing example of, say, for like someone's on oxycodone, how would you like start buprenorphine if the patient didn't want to just do the stop-start method? You just slowly increase buprenorphine at a dose of like 0.5 milligrams 4 times a day. You go to 1 milligram, 2 milligrams, and then 4 milligrams twice a day ultimately, and stop the oxycodone on day 4. So buprenorphine just kind of hangs around the receptor and slowly displaces the oxycodone, not causing any withdrawal for the patient. With the stop-start example here, you can see that on day 0, they're on their full agonist and they stop 12 hours the day before, and then the next day, that following morning, you would start buprenorphine. And generally speaking, you can do like 2 milligrams like 4 times a day as needed to try to see how often they need to use it. Kind of going back to that study by Dr. Cantor where they used about 10 milligrams per day, and then slowly up titrating the dose depending on how much they're needing for pain. Down below, you have ancillary medications for withdrawal you can also consider for patients. So I want to make this point because I went to Pain Week recently and I gave a talk about like a higher dose buprenorphine that we started for a patient. And a lot of people brought up some great points to me that you may not need such a high dose of buprenorphine like Suboxone or Subutex for analgesia. So if we're just looking at it as a very simplistic model, but the mu-opioid receptor is in orange and buprenorphine is in dark blue, uh, you really only need about 5 to 10% of the mu-opioid receptor occupancy to be occupied to achieve analgesia. So this can be from like anywhere from 2 to 4 to 12 milligrams per day total of buprenorphine. For craving or addiction, you really want to occupy 50 to 80% of the mu-opioid receptors because you're trying to blunt any craving for other alternative opioids. So that's when you would use a higher dose of 16 to 24 milligrams per day. So it's something that I wanted to point out because you really need to consider that when you're dosing buprenorphine or Suboxone or Subutex. So lastly, there are realistic considerations with buprenorphine. So if you're going to start someone on Suboxone or Subutex, you really should understand if your hospital is able to employ the use of buprenorphine inpatient. This would be ideal because if someone comes in for crisis, you can give them IV buprenorphine, which works very quickly. It is very costly though, so you have to be aware of the cost, and if your hospital is willing to take on that kind of increase in amount of cost. Hospitals should consider educational rollouts for how they would treat acute vaso-occlusive crisis if they don't have access to this buprenorphine intravenously or IM. So if someone comes in on Suboxone or Subutex, you can reduce the dose to allow for increased mu receptor occupancy. And you can even put a note in someone's profile if you have Epic in your system that can be like, this patient's on Suboxone Subutex. This is the regimen that works for them when they come in for acute crisis. I work with Cerner, so we're a little bit more outdated, and I used to come from an Epic system, and this is a great feature that we would use for patients coming into the ER. And then the outpatient center should really be appropriately staffed to see if you can increase utilization in the initial weeks of the trial. So we saw a 2 times increase in non-acute care access in the 6-month trial. So be prepared to increase the amount of visits you're going to be seeing for patients initially until they get stabilized on a dose. And then lastly, potential stigmatization of patients on buprenorphine at outpatient pharmacies. So not so much with Butrans or Belbuca, because those are like they are FDA approved for pain, but with Suboxone or Subutex, I have had times where I've had to have conversations with pharmacists about the indications for it is for chronic pain. So if you can write that in your comment section, if you do prescribe it, or even call the pharmacy to let them know, hey, this is for chronic pain, like this is a very valid indication for sickle cell. That way you can build rapport with your pharmacies. So that is all I had. If anyone had any questions regarding it.
Good
I
morning.
think you're muted.
This is Raina. I'm at Methodist Sickle Cell Center in Memphis, and I have a question for you. I have quite a few patients that are on Suboxone for chronic pain, but I have a challenging patient who did perfectly fine with initial induction. But however, due to multiple, hospitalizations, the medication was stopped, and when she got reinitiated, was never able to get the full analgesic effect. And so I'm having a difficult time trying to get her back on a dose where she is controlled. Do you have any suggestions on how do you overcome that hurdle?
Yeah, so are they still receiving full agonist agents right now?
No.
Okay. So yes, so I mean, like generally speaking, are they using anything for pain like PRN or?
The only thing that she has is the Suboxone, but when she comes in for like an acute, if it's a walk-in for pain crisis, we will reduce the dose of the Suboxone that she takes that day to allow for room in the receptor for the short acting. But other than that, she's just on the dose. I believe she's on 28 milligrams per day of buprenorphine right now.
Okay. So yeah, so it's a pretty high dose. Like I would say that learning more about buprenorphine for analgesia, you don't have to like cap out and go past like really 12 to 16 milligrams per day, because then you start to see that occurrence where they got to keep reducing the dose, and it may even like block the effects of like short acting opioids when they come in for crisis, and they may really not like that. But generally speaking, you could try them like to do a couple 2 milligram doses like 4 times a day to initially start, and see how they do with that and the total daily dose, and then you can like slowly increase from there. It's like they're going to say it's much smaller doses, but that's an area to start. If they can tolerate that, you can even use like 4 milligrams, and you could do like 4 milligrams 3 times a day as needed and see how they do on the first day. But I'm like more tentative to do doses that are past 24 milligrams if we don't have IV buprenorphine, because there aren't providers, not every provider is knowledgeable to reduce the dose of buprenorphine. So if they just continue it and they're giving like high doses of like Dilaudid and it's not getting better, and like they start to worsen or decompensate in the hospital, it can be like damaging to patients. So like we have to kind of be careful about being aware of that and teaching the hospitalists.
Okay, and what we do at our center, we have a fellowship program with the Addiction Medicine Center here in Memphis, and they help us to get the patients initiated on Suboxone for their chronic pain, so kind of the off-label use. So I'm not actually prescribing, but we're working together to try to get the patients on a dose that is, optimal for them. But I'm just kind of like, what do we do with this patient? Because I'm kind of like, should we reduce the dose of the 28 since it's not working, and try her on, like you said, like a smaller dose to see if that would be more effective for the patient.
Yeah, I mean, like it might be beneficial, and there is more mu occupancy availability on the lower dose, so they can still go into the hospital and continue the dose at 2 milligrams 3 times a day, 4 milligrams 3 times a day, and still have the availability to receive a full agonist agent, PRN. So that might be an area of opportunity, and they could use it as needed too, outpatient. So.
Okay, thank you.
Thanks for that question.
While we wait for anybody else, I had a quick question. So when we were talking about Butran patches, say we have a patient who they have chronic pain, but they're more conservative and whatnot with their pain management approach and just don't like taking medications often. Sometimes when we find that they're having more chronic pain, well, the next step might be adding fentanyl patch to reduce the intake. But now learning more about Butrans, how would you determine which method or which treatment option to optimize from a pain management standpoint? Like,
Yeah, that's a great question. So fentanyl patches, I want to make sure the patient is not opioid naive when we start. So the most indicative thing of that is, are they taking 60 milligrams of morphine per day? So that is from the manufacturer package insert from fentanyl patches. So if they're not taking 60 milligrams of morphine per day, they automatically are disqualified for a fentanyl patch. It's kind of a rule of thumb that I use. And then for Butrans, if they're not using at least 60 milligrams of morphine per day, that's totally all right. They could be using, say, 0 to 30 and still start on a Butrans 5 microgram patch. And if they're on, say, 30 to 60 even, or 30 to 80, you can still do a 10 microgram patch. So Butrans is much more benign than a fentanyl patch. And I find that patients, the only thing that happens with Butrans is sometimes they get some skin reactivity where it's itchiness, and you can actually spray Flonase on the area before you apply it. And that's like a little trick I've heard from some other pain pharmacists, but it's pretty benign therapy that can, for a side effect profile, that can help with pain.
Thank you so much. And is it lipophilic like fentanyl as well, where you want to put it where there's fat, or does it not matter with the absorption?
Yeah, you can still put it on the areas of like the deltoid. They have it on the chest and chest wall, so I don't think it matters as much. But yeah, I would just do the same areas as the fentanyl patch. Actually, it's pretty similar. They do the chest, scapula, deltoid, and then the chest wall is the only different site for Butrans patch.
Awesome. Matt, you're the best. I honestly appreciate you so much and all the help that you provide to our patients. Are there any other questions or comments? If anybody wants to unmute or put them in the chat box before we switch over to the case presentation.
I was just going to ask if we could get a copy of this presentation to have afterwards, if that's possible.
Sure.
And then also, I was just curious if in the case of patients that are having like talk screens that are indicating illicit use of substances, I'm just wondering at particular centers if you refer to addiction medicine or if you kind of try to continue to manage buprenorphine yourself.
Yeah, it's tricky. It's a good question. I think it depends on the provider's comfortability. Like, I work in palliative care as well, and we see this a lot where it's concomitant substance use disorder in palliative care. And I think like we try to risk mitigate as much as possible. So if it depends on the drug they're using too. If they're injecting fentanyl, like that is a much potential. It's like everyone's addiction is like different, I guess you could say, versus alcohol use disorder or cocaine use disorder, which we see here in Miami a lot. If you're not comfortable with it, I would definitely seek advice or help to work collaboratively with addiction medicine. I have like a lot of training in addiction medicine, so I'm more comfortable with it. And like I also want them to be involved too, though. So like I want them to get care from someone who can truly see them every day potentially. Because if they need to be on methadone, for example, you can't dispense methadone from a regular pharmacy for OUD if they have opioid use disorder. So like that, in that case, you would definitely need to speak with an addiction team because they need to go to like a methadone clinic to get it every day. So I think it depends on the patient case. I know it's not the best answer, but and how comfortable you are with like treating the patient, but try to risk mitigate. Alcohol, cocaine. I always tell patients too, like if they're using cocaine, there's a lot of fentanyl in cocaine nowadays. And this has unfortunately led to some inadvertent overdoses. So prescribing Narcan when appropriate is really very valid, as well as fentanyl test strips. I don't know what state you guys reside in, but Florida finally approved fentanyl test strips for patients if it's not drug paraphernalia. So like they're not going to get arrested for it if they are using those kind of things. But yeah.
Awesome. Thank you so much, Matt. We'll share the presentation. Thank you so much to everybody who is interested. And with that, we were going to turn over to Shannon Carroll, who is an advanced practice provider manager at the Johns Hopkins Sickle Cell Center for Adults. She's worked at the Sickle Cell Center for the past 5 years as a nurse practitioner. And previous to that role, she was a nurse in hematology and oncology. So Shannon, I'll let you kick off your case and we'll take it from there.
Awesome. Thank you so much. I'm just going to use the sheet that you guys have, if that's okay. So I'll just tell you when to scroll down. So this is a 33-year-old female. She's got hemoglobin SC disease. She was admitted on November the 1st for induction of labor. The past 30 days, she had one admission for unsickle cell related events for her pregnancy, just because she had some gestational diabetes. Otherwise, with regards to her sickle cell, she has had 7 admissions in the past year for acute vaso-occlusive crises. Her level of care would be, obviously she's on L&D, but it's basically like, med surg level. There's nothing acute with regards to her vital signs. She typically follows outside of our institution, but came to us in July in the setting of her pregnancy. And has seen one of our attendings, Dr. Pecker. She does not have a primary care provider. She has some complex chronic pain. It sounds like she had this pretty significant gas explosion accident in which her back and her neck has this like daily 7 out of 10 pain. She tries really hard just to take nothing, use heat, but ends up needing to use oxycodone about 5 to 15 milligrams in a total 24-hour period. Other medications, she's on a baby aspirin for her pregnancy with regards to her risks to preeclampsia. She takes Flexeril, and then she's on a prenatal vitamin with iron. In the last 24 hours, with regards to pain, she got 8 milligrams of IV morphine, and then because she was induced, she had an epidural with fentanyl and bupivacaine. She's on a bowel regimen. Her past medical history includes acute chest syndrome. She's not had any type of stroke or DVT-PE. Her surgical history includes a cholecystectomy, a shoulder decompression for some AVN, and then she's had a miscarriage needing a DNC. She does not have pulmonary hypertension, renal disease, or iron overload. She has some pretty significant major depression and anxiety history. From what I can see, there's no concerns that this depression is truly something else like a bipolar. There's no concern currently for any substance use disorder or any aberrant opioid use. With regards to her psychiatric care, because she's so anxious about her pregnancy and has this history of depression and anxiety, we had her see our psychiatrist that works really closely with our patients, Dr. Prince, but she's not on any medication management with regards to her pregnancy. She's not on any hydroxyurea, nor has she been on it in the past with her hemoglobin SC disease. For her pregnancy, we started her on chronic transfusion therapy, so she was getting that monthly. She does not have any history of red blood cell alloimmunization. She did get transfused last on the 31st prior to her induction. Her vital signs yesterday showed that she's afebrile with a temp of 36.8, her heart rate 71, blood pressure 128/80, and she's statting 99% on room air. Most recent labs. So she lives at a baseline hemoglobin of 11 to 10. Her most recent hemoglobin, this was last night, was a hemoglobin of 10.8. This is after her delivery. She did have some blood loss, but her hemoglobin's still at baseline. Her white blood cell count is 11.55, neutrophil count of 8.68, MCV of 91.4, platelets 264. Her retic has not been drawn, unfortunately. Her most recent hemoglobin electrophoresis was prior to the transfusion on the 31st, which showed a hemoglobin A of 31.9%, S of 30.9%, and a hemoglobin C of 31.9%. Her creatinine is normal 0.6, a relatively normal T-value of 1.2. No need for urine tox, and I don't have any radiology imaging to report. So some of her social information that's kind of interesting is, so she's a high school graduate with some college. She's self-employed. She's a baker, soap maker, and walks dogs. Some relevant social history is she's had a miscarriage in the past. And prior to her pregnancy, she smokes marijuana for some chronic pain relief, about 3 to 5 joints a day. She did notice some significant increase in pain and some emotion labile upon stopping her marijuana usage. She has state insurance. She lives with her husband and 2 dogs, no childcare or transportation information that I'm aware of. I don't think she has any other children. But this is her first, I believe this is her first child that was born on the 3rd. You know, some really exciting news is that she gave birth to an extremely healthy, chubby 7-pound, 14-ounce baby boy, which is like pretty unusual for some of our patients. You know, they tend to have smaller weight babies. So that's really awesome. She was in labor for 24 hours with some slow progression after rupture of her membranes and initiation of Pitocin, but had otherwise an uneventful C-section. What's really great to note since starting her on transfusions is the fact that she hadn't had any hospitalizations related to her sickle cell at all. And before that, she was getting admitted, you know, 7 times in a year for pain crises. Last night, after having the labor and all the stress of that, she started to notice some of the sickle cell crisis pain in her back, legs, arms, and at the C-section site. So we kind of started our patient-specific treatment plan in which we were going to start giving her morphine 6 milligrams IV times 3, and then start her on a morphine PCA. And then some other kind of like background things that kind of go into like my case questions are, you know, this young lady's relatively new to us. We just met her in July. She's had some significant mental health issues throughout her lifetime. She reported first seeing a therapist in childhood and has had some suicidal thoughts as early as 10. She actually has attempted suicide a few times. When she was 13, she went on the roof of her school. And then again at 18 and 27, where she admittedly tried to overdose by taking some opioids, but was not successful, thank goodness. And it was not significant enough where she needed to seek out medical care with these attempts. In her 20s, she was a victim of sexual assault and had some pretty significant and has had some pretty significant depression and anxiety symptoms that continue today with some flashbacks, nightmares, and some pretty high anxiety. And then, you know, to make things even worse, she had that horrible gas explosion that I kind of mentioned in the beginning that complicated some of her chronic pain. And she, during this explosion, had lost all of her personal belongings. And then in general, she just has a really high distrust of healthcare providers. So I guess I tend to interrupt Ashley and summarize my own case. Do you want me to keep going or should I stop?
You can say what you're trying to get out of the case, and then I can summarize. We can ask some clarifying questions before.
Okay. So this is a 33-year-old female with hemoglobin SC disease who prior to pregnancy did not have a lot of significant disease management due to her SC disease. However, had a lot of complex chronic pain and frequent hospitalizations. She came to our infusion center for her pregnancy to kind of get better control over sickle cell and help support her through her pregnancy through chronic transfusions. We saw a significant decrease in her acute care utilizations with regards to pain, and then are really happy to share that she had a very successful delivery of a healthy baby. And we're just trying to figure out like, where do we go from here with regards to like having her trust us. She's got this pretty horrible and significant anxiety, depression background, which, you know, I think we are a little bit more on high alert because of the high risks of having postpartum depression, and I'll kind of stop there.
Yeah, I think this is a really interesting case. One, just having hemoglobin SC and being managed on chronic transfusions isn't necessarily a common practice or as clear cut when we think of standard of care and whatnot for pregnancy. And she clearly has a very significant mental health history, just given her the sexual assault. I'm sure there's some PTSD from that gas explosion, that there is a very multimodal approach when it comes to managing this patient. Does anybody on the call have any clarifying questions when we're trying to give recommendations for how to best manage this patient? Please give me a moment, sweetheart. I think the fact that she's open about her history, her mental health history, is a positive sign that hopefully addressing her mental health will be a success. And when you're asking how to build trust and engage in mental health care, you don't want to overload in that first appointment and the beginning where you're really just trying to nurture trust and build that patient-provider relationship. That I think that the key for any type of patient-provider relationship is just validating their experience and understanding what they've gone through and kind of normalizing it. Stephanie Bankston's on this call, and she's an amazing nurse practitioner, part of a CBO locally, and maybe connecting to a local CBO where they can connect with other warriors and people who might have experienced something can help normalize and kind of break the stigma. Because when we think about just when it comes to addressing mental health, a lot of times people think they're their own unicorn and the only one dealing with a lot of these issues. That I think normalizing it and connecting with peers who may be a new mom and how navigating that would be beneficial. I think, Matt, I mean, you're talking about prescribing opioids and buprenorphine. It seems like just given her history and attempts for overdose, it seems like buprenorphine is probably a safer option just to reduce the risk of respiratory depression. Please give me a second, sweetheart. From that standpoint, I'm sorry, it's election day and luckily they close all of our kids' schools. So I'm sorry for the background noise.
Yeah, so I think like one of the things that we're gonna try, so we're gonna try to continue to engage her with like chronic transfusions just because she said did so well with her chronic pain that our thought is like support her during this like very challenging period for any new mom, like, right, like you're not sleeping, like your pain is probably going to creep up. So, you know, our thought was like, let's continue to do these transfusions until she's no longer breastfeeding, or at least 6 months. And then maybe over time can try to like build trust and maybe start the buprenorphine conversation, especially because it's safer for baby and safer for mom with regards to her history. So
Matt, just since you're on the call, how does it work with I know for regular opioids and the recommendations with breastfeeding and pump and dump, et cetera, is it the same or what's the typical, just since?
Yeah. I mean, like, generally speaking, they say that the risks of any opioids versus the benefits of breastfeeding are like the benefits of breastfeeding are greater than any risk of like opioid, in general. So that's the first thing I want to just address. Buprenorphine is safer though, than like a lot of other opioids because it's a partial agonist and it's not like codeine derivative where like it would be concerning for a baby if they were be a rapid metabolizer and like have respiratory depression. Um, but yeah, like I mean, and going off this case too, like a lot of it sounds like a lot of like when we talk with patients with like for our addiction medicine, they're very again like they don't want to talk to a lot of providers because they've probably experienced a lot of like biased treatment care in the past, especially someone who's experienced sexual assault. They're probably very guarded, reasonably so. So probably honestly, it seems very simple, but getting to their level when you're talking with them and like whether they're at the bedside, like sitting in a chair next to them or like getting low, like actually helps to talk with a lot of patients and engage and build rapport and just kind of hear them out and again, engage with psychology. I think that'd be good if you even know of a good psychologist. We have a couple of really good ones here at our hospital and just kind of try and explain like, hey, I'm here to help you. You know, like I know you've experienced a lot of stuff in the past and we don't have to talk about that. And like that, unless they wanted to express those things. But just some things I noticed too.
Great suggestion. And there's 2 questions in the chat as well. Are the transfusions modified or is it pheresis? And then how often do you plan to transfuse?
So good question. So we do simple transfusions, so just 2 units of blood, but before we infuse them, our nursing staff does a draw off of at least 400 milliliters, which we think to be about 1 unit. In pregnancy, our attending is okay if their hemoglobin is a little bit higher than 10. We try not to go too much over 11 just because of the concerns for hyperviscosity, but the thought is it'll help with the baby to grow and develop instead of having like the lower hemoglobin. And then we tend to transfuse about every 4 weeks during pregnancy and after. In the perfect world, we would continue transfusions for moms for as long as they would breastfeed. But if they choose not to breastfeed or there's, you know, issues with latching or whatever, then we tend to only do about 6 months.
That is best. And I think also just being proactive with your conversations with her, just to clue her in about the postpartum depression and just what symptoms to look out for. Because to us, we know this, but for patients, they might not, they'll be so sucked in and sleep deprived that they might not be on the lookout for that and just get really because baby blues are very serious.
Oh, yeah.
And I
Yeah.
loved Matt's suggestion, like getting on eye level and just taking a seat, it makes such a difference. And I think especially in the hospital setting, so many times you'll just have all of these people standing around your bed and just think of how that would feel from that standpoint. So I think just humanizing the experience, getting on their levels, being proactive with the conversations, and just getting to know about her and her business and what's her favorite flavor of soap, what kind of dogs does she have? Because I think a lot of times when we learn more about the patients as opposed to just their sickle cell and condition we're treating, that's what brings that building trust and allowing them to trust you. Because when we're thinking about just unrelated sickle cell clinical trial participation, and there's a huge distrust, you think about just all of the countless instances of medical exploitation, et cetera, we always have very high recruitment rates, and it's because our patients truly trust us. And I think when we view our patient-provider relationship as a partnership and not kind of a patriarchal way where it's like, this is what we're doing and we're making the decisions, we're really trying to involve the patients in their care. That shared decision making really is just going to improve health outcomes. And from a provider standpoint, there's benefits as well. And then Stephanie had said, great case study. I was wondering if you have another warrior mom that could speak with, as that could be supportive. In addition, joining a sickle cell support group may benefit her as well. I totally agree. I think this is where the CBOs can provide so much additional support. And if you have a good program where you have a nurse navigator or social worker, depending who does your outreach, I would put her on my radar and just call her once a week or email her once a week and just check in and see how she's doing, how's new mom life going, et cetera. So if she does have an issue, she's more likely to reach out to you for any potential problems.
That's a great idea. Thank you.
It's a hard history. The mental health piece. Again, there's so much when we think about treating sickle cell. Sickle cell is only a drop in the bucket. There's so much more just from their psychosocial that we need to play, just understanding the interplay of mental health and physical health. Awesome. So I think overall you have a great new patient, and you have the potential to really help and improve her life. This is definitely a big transition period and a big next step chapter for her in her life, becoming a mom and starting that family. And anybody with kids knows that adds a whole new level of stress and anxiety than baseline. So I think the mental health piece is going to be the most important to address, and just creating that rapport and positive relationship over the next few visits while you're learning about each other, et cetera. And I would just periodically check in on her, because I was surprised at how emotional the postpartum blues were. Very intense for me, and it was like weeks out. It wasn't even like immediately after delivery as well. Awesome. So this was a great topic today between Matt on buprenorphine and then Shannon's case, just a pregnant patient with VOCs, but did really well once you started on chronic transfusions, and just a complex mental health history, just showing that there's so much more to sickle cell beyond just the management of pain, and we can make such an impact on these patients. So that's it for today's session. We're doing sessions the first Tuesday of every month at 9 a.m. There's multiple sessions and echoes that we can send out the schedule, so you can always find ones that work for you. If anybody is ever interested in presenting, it's an awesome opportunity. It's only 20 to 25 minutes. So if you're new to presenting, it's just a very good experience and not intimidating. We love to learn from each other. If you ever have a complex case or something you want to share, please reach out to us. And the CME credit link is in the chat, so we can all claim those credits. And with that, I will let y'all out with 2 minutes to spare, and hope everybody has a happy Tuesday and go vote.
Thank you.
So take care, everyone.
Have a good one.
I think they're probably, that was pretty good. I'm texting Ashley on the side. I'm like, even when I try to be proactive and get everything taken care of, there ends up being something, and then rocks the boat and whatnot. But thank you so much for your help. I appreciate it. And I hope you have a great week.
Yeah, thank you so much. It was great meeting you.
Likewise, take care.
Mhm.